Stroke is the leading cause of disabilities in adults. And the bad thing about stroke, if it don't kill you, it's going to affect you years later. For the rest of your life, it could decide whether you have functional independence or whether or not you have to live in a care facility, full-time care facility, have people, take care of you. And that's what's bad. Now, the last time we had any data was 2018 or 2019. This comes from the CDC. But look at that number there, 56.5 billion in 2018, 2019 for stroke-related medical cost. That's everything, okay? That's the ambulance ride, that's the hospital, that's the full-time care facilities, that's all the medication, equipment, whatever procedures has to be done because of stroke. But 56.5 billion, and a lot of that comes from Medicare and Medicaid. And you know where Medicare and Medicaid comes from, right? Look at your check stub, because we're paying for this. As of 2024, there were 6.4 million survivors in the U.S. Only 50 to 75% of stroke survivors regain functional independence. And part of the reason for that number is so high is because they wait to get help. And you're going to see, as we talk, you can't wait when it comes to stroke. But only 50 to 75%. So that means, anywhere from 25 to 50% of them can go on to have full functional independence. And then this last one is really staggering. According to the National Stroke Association, 80% of strokes are preventable if risk factors are managed. That's unacceptable, right? So again, that's the reason for this program, to teach you about some of these risk factors. There are risk factors that you can't do anything about, but there are a lot that we can do things about. And the more we can do to help, the greater our chances are, to help prevent that person having a stroke. But look at that, 80% could be prevented. 795,000 strokes annually, average somewhere in that neighborhood. If we did reduced 80% of those, that could be phenomenal. Okay, so women and stroke, we talked about a little bit. Stroke kills more than twice as many American women every year as breast cancer. Breast cancer gets a lot of publicity in the public, right? You hear a lot about breast cancer, and that's good. We need to hear about it. We need to hear about it. But you hear a lot more about breast cancer than you usually do about stroke. And stroke kills twice as many people as that breast cancer. So we need to do as good as the breast cancer awareness folks, and we need to get that word out there. More women than men die from stroke, and risk is higher for women due to higher life expectancy. Just because you're going to live longer, and then usually women suffer greater disability after the stroke. That's because if you have a stroke at an older age, it's going to have more negative effects on your recovery and your body. So we talked about all these things of stroke. So what is stroke? What exactly is it? Well, stroke is when blood flow to the brain is interrupted. That means it's blocked or something happens to interrupt that blood flow. Then that oxygen and that glucose that's in that blood doesn't reach your brain cells. When blood does not reach your brain cells, brain dies. And the longer you wait, the more brain, you'll see later, the more brain will die. But that's exactly what stroke is. And there's two causes, or two main causes. There's a clot, or a blockage, or it could be a ruptured blood vessel. So these two things, when one of these two things happens, regardless of the reason, that blood now is interrupted, it doesn't get to the brain, the part of the brain that those blood vessels feed will begin to die because they have to have oxygen. So if you look at a brain, now this is pretty complicated. It is color-coded just so you can see, but there's billions of blood vessels covering that brain. The brain demands more of everything in our body. It demands more of our water. It demands more of our oxygen. It demands more of our glucose. And the way that all gets there is through these blood vessels. And if you look at all these blood vessels, arteries, veins and stuff, it just covers them, not only on the outside, but even inside. And those blood vessels are supplying that brain. So you can see there's different sizes of blood vessels. So the smaller the blood vessel, the more acceptable it is to get blocked. So just a small clot the size of a grain of sand might cause a problem in one area of the brain where it may be able to get through in other areas. So that's all there. Now that's pretty complicated to look at. So let's look at a way to make it seem easier to us. Let's think of it as brain plumbing. Now this is an image of my brain here. The last time I took an MRI at the hospital, I can tell by the rusty pipe that's there in the top. But you can imagine. Think of your plumbing in your home. You got a big line coming in, right? Now that big line breaks down and it starts getting into smaller lines that's supplying all areas of your home, your sinks, your tubs, outside faucets, whatever. But as we saw earlier, when we have trouble with plumbing at home, we're either going to see a break in our pipes, or we're going to see a clogged pipe, and that's what causes what keeps water from getting where it needs to go in our house. So you can have a clog or a break in one part of your house that may not affect another part. So it's only going to affect the part that it's feeding. It's just like our blood. So if we have that stroke now, depending on where we have that stroke, may determine whether we fall dead immediately, or we're not able to use our right arms, or we're not able to speak, or we're not able to do those things. So it's a gamble. It's a coin toss on how that stroke is going to affect somebody. It all depends on where it's going to happen in the brain. But there's two types of strokes, and you don't really need to remember the names if you can't, but there is what we call a hemorrhagic stroke. This is the burst vessel, or the burst an aneurysm, if you'll see there on your left. So at home, our pipes can burst and break, right? That's what a hemorrhagic stroke is, when that blood vessel bursts or breaks, and now that water or that blood can't get where it needs to go. Thanks, guys. Now, so it can't get where it needs to go. Well, that's just like a burst pipe, right? Look there on the left. A burst pipe keeps that water from going where it needs to go. A burst blood vessel keeps that blood from going where it needs to go. But that's called a hemorrhagic stroke. Then on the right, you have an ischemic stroke. Ischemic strokes are blocked vessels. That's like our clogged sinks, our clogged drains. Something has either went in there to stop it, it's built up a sediment over time, and now everything is blocked, and it doesn't let the water or the blood flow through. If you'll look at the left side of the brain, you see the bleed from the burst vessel. That can be either inside the brain, it can be outside the brain, over the brain. Doesn't matter, but we just know that there is bleeding in there. And then, if you look at the right side, there's going to be a blockage. And just like we said earlier, that's from a clog. So look over here at this clogged artery or clogged vein here on the right. You see how it's got that white stuff building up in it? That could be like plaque that builds up in your blood vessels over time. If we don't eat properly, or we eat a lot of, high cholesterol can cause it. And then if it gets narrow enough, it doesn't take a very small blood clot now to stop it up, block it up. This is just exactly what happens in your pipes at home. Over time, all the debris that goes down that sink, it's going to eventually clog that up. Now here's the thing. Each one of these are treated differently. You cannot treat a hemorrhagic stroke like you do an ischemic stroke, and vice versa. Just like your pipes, right, in your home, you gotta treat them differently. And one is a little bit worse than the other one. If you got a burst pipe, that's going to be a little bit harder to fix, more expensive to fix. It's going to, it may require you to dig things up, tear walls out, whatever. But it's worse if you got a busted pipe. It's easier if you got a clogged pipe. because now there's some things that we can do to try to break that clot up and get that blood flowing through there. But both are treated differently. Now, I think we've all been here at one time or another, right? So this is what we would see as an ischemic stroke. Ischemic stroke, if you remember, it's a clog. The sink is clogged up. So what do you do? Well, there's several things we can do. We can take a plunger, we can take a snake, we can call a plumber, we can do all things. But the simplest thing that we can do in a situation like this is we can use Drano. You pour Drano in. What does Drano do? It breaks up all the clog and debris and hopefully lets that water go on through. Well, there's something like that, like the Drano that we use for ischemic strokes. It's a medication, and for short, we call it TPA or TNK, but there's two different climbs, but it's clot busters. So think of this clot buster as Brano. So we got Drano for our sinks, we got Brano for our brains. And we give this medication if they can. Now there's things they have to go through to determine if they're a candidate to receive this. But if they can give them this medication. It's the quickest way. It's the easiest way. We don't have to do surgery on nobody. We don't have to do any type of invasive maneuvers on people. But here is the key behind this whole thing. The Brano can only be given within the first 4.5 hours of the onset of stroke. So it's time sensitive. If the person waits longer than that or gets to the hospital longer than that, then after 4.5 hours, we can't use the Brano anymore. So, but it is the most ideal treatment. It's the most effective. It gets everything going quicker. Gets more blood going through the brain quicker. So this is our top choice. Yes, sir.
Hey, Rob, when they're estimating this time, do the doctors estimate when it starts? I mean, period, you call 911, so they know it can start at least at 3 o'clock.
Right. Okay, so here's what we have to know from the people that called. There's something that's called the last known well time. So this is the last time that person is seen. And from my understanding, they're real particular about this, because if you can't tell them the last time they were seen well, then they probably won't give it to them. So let's look at an example. Let's say you go in at lunchtime, you've been mowing the yard, you go in to watch the ball game, and your wife brings you a sandwich or whatever, sets you down there at 12 noon, you're kicked back in the recliner. She's talking to you, you're talking to her, everything's normal. She goes back back in the backyard, works the flower bed or whatever. She comes back in 45 minutes later, and now this husband has showed signs of stroke. The last known well time is not at 12:45. The last known well time was at 12 o'clock. You go bed at night, you're normal. You wake up the next morning, you're not normal. Well, that was 8 hours ago. So guess what? They probably won't give you the Brano because of that. And there's some reasons why, and we're going to look at why that's so important later. But it's a good question. Thank you. And guys, anytime y'all have some questions, please feel free to ask. All right, so is everybody with me so far? This is the number one way we want to treat people. It gets the faster results, the better results, less invasive procedures. You can look here. I don't have a laser pointer, but if you can see that bright area right in the center of the brain, that should have blood vessels going all over it like the rest of it. This is an image of an ischemic stroke. So this is before they give the Brano, and if you look at it after they give the Brano, now look at all the blood vessels. So that Brano has been given, it's took that clog out, now the blood flow has returned, and it gets in. I'm sorry? No. Good question. Ambulance drivers do not carry that. It's only going to be given at the hospital by stroke-ready hospitals or hospitals that participate in the stroke programs and are, medically equipped enough to give this. But here's the thing, and we're going to find out later. When you have a stroke, remember we said there's a hemorrhagic stroke and there's an ischemic stroke. Now here's the problem. You can't tell which one they're having just by looking at somebody. The symptoms are the same. The only way we can figure out if it's a hemorrhagic stroke or an ischemic stroke is they have to do an image of the brain. They have to do an MRI. So you see that now more time. So you see now why it's more important to get there quicker, because now we got to do an image, because we can't treat the burst pipe and we can't treat the clogged drain the same way. If you pour Drano into a burst pipe, it's not going to do any good, right? So because of that reason, then it does take up more time. Okay, so what if they're not a candidate for the Drano? What if the Drano doesn't work? If the time is too long, or maybe after they evaluate the patient and talk to the patient, they may figure out they can't take this because of whatever reason. Some other medical condition, they may be allergic to something that's in this stuff or whatever. So if they can't give the Drano for whatever reason, the next option is, if we had a sink, we're going to use a drain snake, right? And we're going to run that down in there and we're going to dig that thing out. Well, just like with that, there's a brain snake. And this is what's called a thrombectomy. If you can see, a thrombectomy works like a drain snake. They're going to run it probably down here at the bottom of your leg. They're going to run it all the way through your body, and they're going to have to get up there, and they're going to have to take that drain snake and try to break that clot free or pull it out. You can see this is a lot more invasive. Which would you rather do? Take some medication or have a brain snake run through your body? More complications, more problems, more expense. It just makes everything worse. So we want to get that TPA if we can. If not, our next option might be a brain snake. Here's some pictures of a thrombectomy before and after. Look at the picture on the left. You see that arrow? That is a blockage right there from an ischemic stroke. On the right, after the thrombectomy, look at how the blood flow has returned. Can you see that? So there's some images there then that can show you how effective the thrombectomies are. All right, so how are we going to treat these? I'm sorry, guys. I don't know what's wrong with my voice. But we treat them differently. So these are the treatments. Now, we already talked about the ischemic stroke, the clots. Our number one thing is we want to try to give them the TPA or the TNK, but we only have 4.5 hours. And we have to, if you call 911, try to get that last known well time if you can. Try to figure that out before they get there. So what the ambulance will do is they would take them to a stroke-ready hospital. Our SAVES program we're going to talk about later on, which is telemedicine. They'll be able to get online with a vascular neurologist. It's on call 24/7. They're going to call him up. They're going to get like a FaceTime there. They got these screens. The doctor, the neurologist can see the patient, talk to the patient, talk to the doctors there at the hospital, and then they can the vascular neurologist can give them a course of action. Okay, let's give them TPA, or let's do a thrombectomy, or if they can't do that, you're going to have to load them up and ship them to another hospital. So they'll tell them there what they need to do. And then if they can't give them that medicine, of course, they'll do those clot removing devices like the brain snakes and those kind of things. But that's how you treat an ischemic stroke. Now, hemorrhagic stroke are completely different the way we treat them. A hemorrhagic stroke, which is a brain bleed, that's going to require brain surgery. They're going to have to open you up, and you got to do a lot more. Now, the ischemic strokes and the hemorrhagic strokes. There's 87% of strokes are ischemic strokes. You don't want to have a stroke, but if you did, an ischemic is going to be the easiest to treat, so I'd rather it be an ischemic. The other 13% are the hemorrhagic strokes. Even though the hemorrhagic strokes are fewer in number, they take the most lives. So the life expectancy from hemorrhagic strokes is a lot less than from somebody that has the ischemic stroke. They just kill a lot more people. So we talked about stroke. We talked about what it is. We talked about how it can be treated. So now we need to be able to recognize when somebody's having a stroke. And this is where the big part, the meat and potatoes of the class comes in, is educating you on how to recognize if somebody's having a stroke. So I brought some little things today. Alan, you want to pass those out to everybody now? But I give you some magnets that you can hang on your refrigerator. I'll give you some pens. Every time you click it, you'll see it's got a BFAST acronym in there. All right, even got some carabiners there. Y'all may not be interested in this stuff. If you're not, that's okay. So, be fast. So here's a story. My father-in-law, I gave him one of these magnets that you just got, and we hung it on the refrigerator. My mother-in-law had a stroke. He was able to recognize she was having a stroke because I'd educated him, and he saw that magnet hanging on the refrigerator, and he was able to call. So it makes a difference. And I teach a lot of first aid, CPR and stuff, but I think seemed like the thing that most people come back to me and say is, hey, Robin, my grandparent, my parent had a stroke, and I was able to recognize it because you taught us that BFAST acronym. And I get more reports on that than I do a lot of the stuff that I teach. But let's take a look at it. Be fast. Each one of those letters stands for something different. So the B stands for balance. If you have somebody that is acting normal and all of a sudden, like flipping a light switch, they start getting off balance. Their equilibrium gets interrupted. That can be a sign of a stroke. My brother had a stroke, and he was driving down the road in a car, and he said it was like the world turned on its side. So you can imagine his equilibrium when that happened. So anything that have to do with that balance or equilibrium that comes on quickly is a sign of stroke. The E stands for eyes, and we're talking specifically here about vision problems. So these vision problems can show up different ways. You can have blurred vision. You can maybe just have blurred vision in one eye. You can have partial blindness in one eye, or it can even cause you to quit seeing altogether. But a sudden loss of vision, eyesight, if it's interrupted, that is a typical sign of a stroke, something that's going on in the brain. If you know about, and this is taking you a little bit further, but you know what the pupil is in the eye, right? It's that dark spot right in the middle of the eye. If you look at somebody's pupils and one pupil is really big and it's what we call fixed, it just stays there. The other one is small, so they're different. The pupil sizes are different. That also is a sign of stroke and something going on in the brain. The FAST, the F is for face. And we're looking for facial droop. Now, sometimes it's very obvious that a person's face is drooping. Sometimes you might not be able to see it. So one of the things that we always did, we would say, hey, would you smile for me? You know, the person smiles and one side goes down, one side goes up. You know, you can see an uneven smile. That's a sign there's partial paralysis to that part of the body. So it's going to affect their smile. It's going to affect their face and cause facial droop. You may even see drooling from that side of the face because they're not able to control things. Drool may start to come out. Alan said before he's heard you could stick their tongue out. And if they try to stick their tongue out and they just can't do anything weird with it, that can also show that half of that half that body has partial paralysis. The next part you can see here, the next letter is A, and that stands for arm. Now we're looking at, most of the time stroke affects only half the side of your body. So if the arms or the legs doesn't work equally, that's a sign of stroke. Now what we always did was we would tell somebody to either sit or stand, close your eyes, and stick your arm straight out in front of you. If they did this number right here and they can't control this one, or this one does something strange, but it's not equaling the other side, that's a sign of stroke. Or they may stick it straight out and then this arm start to drift down because they can't hold it up. Again, that has something to do with arm drift or arm paralysis in that part of the body. So that's a good tool that you can do with the arms to see if they're working the same. The S is for speech. So just listen to that person talk. And if you know this, especially if you know this person and they talk usually normally, but now they're slurring their speech, slurred speech is a good sign that they could be having a stroke. It's because half of that side of the body is paralyzed and it just causes them to slur their speech. If it was somebody that we didn't know, we always had a little saying. We'd ask that person, can you say, "You can't teach an old dog new tricks"? Would you say that for me? And if they say that sentence, if they're slurring their speech, they're going to slur something in that phrase as they say it. And then the last is T. That's for time. So time means if they fail any of that BFAST acronym, that BFAST test, just one of them, you are to assume they're having stroke, and we want you to call 911. Now, we're going to talk a little bit later about calling 911 versus not calling 911, but you're going to find out it's going to be best to call 911. And then also, if we can get that LKWT, that's that last known well time, before that, after you call 911, before that ambulance gets there, if you can try to figure out the last known well time, hopefully, especially if this is a person in your family that has a lot of medical problems or a lot of medications, it's always good to keep a list of that medication and those medical issues that person may have it all written down, have you a copy, but have a copy that you can hand to the ambulance so that they can take it with them. Because knowing what medicines and what kind of problems that your medical history is a big factor on how they can treat you and how fast they can treat you. Is there any questions about that BFAST acronym? There could be, yes. Yes, there may be multiple symptoms. Balance is off, face is drooping, slurred speech. You can have one symptom or you can have all those symptoms. But if you even have just one symptom by itself, you are to assume that you're having a stroke and call 911. Okay? What's going to happen if you're not having a stroke? Well, nothing. But if you are really having one, yeah. You are right. Now, so that's why we need to know about your medical history. Do you get dizzy every once in a while? Just standing up or doing something, that may be normal. So we would know but we're talking about somebody that probably never gets dizzy, they never have a problem, and now all of a sudden their equilibrium's off and they can't even stand up for falling down because that's what we're looking for. But it can be one or all. Did that answer your question? Sometimes you have to use your best judgment. If you're on the fence, call 911. All right? That's what I would suggest. Okay, so let's look at a few more facts that you may not have known. Remember, I said you have to get there 4.5 hours to get to TPA. Look at that top line. The average time from symptom onset to the emergency department is 17 to 22 hours. Unacceptable. That person lost the chances of taking the Braino a long time ago. But that, and why, we're going to talk about some reasons why people wait that long. 42% of people over 50 do not recognize signs and symptoms of stroke. That's one of the big things of this problem, big things with this program, is we want you to be able to recognize them. That's why I give you that magnet. And here's the thing, you got homework assignment. So after this class today, I want you to go to an elderly individual in your life, and I want you to teach them about the Be Fast. Write it down if you need to. You can get on websites, and there's some little pamphlets that you can print out, hang that on the refrigerator or whatever, but teach them that Be Fast acronym and how to recognize those signs and symptoms of stroke. Only 38% call 911. So a lot of people don't want to call 911. A lot of people want to drive themselves, or a lot of people want somebody else to drive them. And I'm going to tell you some things later that will help you see why calling 911 is going to be your best option in 99.9% of the cases. But only 20 to 25% arrive in time for that TPA. Unacceptable. We need more people. And the thing is, a lot of people don't know that there's a time limit on it. They don't know I only got 4.5 hours. They don't know that while I'm sitting here waiting, brain is still dying. Brain don't just die when you have the stroke. It dies and it keeps dying. And the longer you wait, the more that brain will actually start to die. But time is brain. And here's something that can help you see, why does it matter? Time is brain. So time lost is brain lost. So look at this ischemic stroke. The onset, you see the red spot? That's the actual blockage. The blue around it is the area that's starting to begin to die. Now look after 2 hours. Look after 24 hours. Look after 7 days, how much of the brain can die. Because everything that blood vessel's blocked, it's supplying blood to we don't know to what part of the brain. But every part of the brain that's getting its blood from that blood vessel that's blocked now is going to start to die. It's going to cause problems. It could even cause the person to die and go into sudden death. So the faster the treatment, the better the outcome. We want everything to move fast. This right here will drive some things home. So again, why does it matter? So the brain cells are called neurons. Let's call them neurons. And every second that you're having that stroke where that blood is shut off, brain cells start to die, neurons start to die. And when they start to die, it's as if, to wrap our heads around it, it's as if that brain is starting to age. Does anybody want to guess how many brain cells dies every second when a person having a stroke? 32,000. So for every second they're having a stroke, your brain is aging 8 hours. Unreal, isn't it? For every minute, 1.9 million, that's 3.1 weeks. Per hour, 120 million. 3.6 years is what your brain ages for every hour. And then the average that most people's brain has aged without treatment, 36 years. Now, I don't know about y'all. I'm 62. I don't need a 98-year-old brain. And I'm not here to brag, but already I'm getting where I can forget what I'm doing while I'm doing it, right? So I can't afford to lose any more of my brain. So time is brain. We need to get them there quick. To help you understand what the ambulances and what the doctors are doing so that you'll understand why you need to act fast and why you need to do what you do, let's look at the pre-hospital guidelines. So this is the ambulance that shows up, the EMS system. So they consider anything that comes in as a stroke or a possible stroke, they're going to consider that top priority emergency. Okay, they're going to run lights and sirens getting there, and hopefully they're going to run lights and sirens to get you to the hospital as well. The EMS, their protocols is to load and go. As soon as they see signs of stroke, they got a 10-minute scene time. So within 10 minutes, they need to have that patient load. By the time they get there, that's their goal, is to get that patient loaded and get them on the road quick. Why? Because time is brain. We got to get them to the imaging machine before we can ever fix anything, right? So they have 10 minutes, and if it's been more than 4.5 hours, they can still do the thrombectomies. Now, we want the TPA, so we're hoping to get there before 4.5 hours, but they're still going to treat it like an emergency. Now, here's the kicker. As that ambulance is driving there, they got a radio, they're going to call the hospital and give a patient report. When that hospital hears stroke, that woman on that radio is going to turn to all those hospital staff, and she's going to say, we got a code stroke coming in. Now that means everybody's jumping through hoops. Everybody knows what we need to do. We're calling MRI. Hey, we got a code stroke coming in by EMS. How long before we can get them there? Okay, we're fixing to do one. We'll hold it, and now we can get our patient in a lot quicker. So you see, you're giving them a heads up before you get there so that they can prepare for what they're about to receive. Sometimes when the ambulance gets there, they don't unload the patient in the emergency department. They just wheel right past the emergency department. They go straight to the MRI machine. How many minutes you think that saves getting that person straight to that MR? If they have to stop at the ER and they have to unload the patient onto a bed, the doctor comes in, talks to them. Now, let's get them to MRI. So now we got to wait for the orderlies to come and get them off the bed and take them to the MRI. All that builds up time. So the goal is to take them directly out of the back of that ambulance and wheel them straight to that MRI machine. So that's why we need to be so fast with doing this. EMS plays a big part in this, okay? So here's some other things. Less than 400,000 acute stroke patients are being transported annually by EMS, which is the ambulance providers in the U.S. So not enough people is using 911. EMS use, in other words, calling 911 and using an ambulance, it decreases the time to hospital arrival and increases the ability to implement acute stroke triage and interventions. So what's wrong with going in POV or your personal vehicle? First of all, you don't need to be driving. So if somebody else is driving you, still going in with your personal vehicle, it's going to take a lot longer. Now remember, I said we got an ambulance over here at Greenbrier. So I'm pretty much, everybody that's sitting right here will get an ambulance really quick. Stroke is the 5th leading cause of death. Stroke can kill you immediately. If you were going to die, you would want that person to go into cardiac arrest in back of an ambulance than you would on the passenger side of your vehicle, right? So let's get them in an ambulance. They're going to be able to treat them. If they do go into cardiac arrest, they're right there. They can defibrillate them and do all that they need to do to work on them. So that's one reason we want to call 911, is because of the care that's going to be provided while they're en route to the hospital. Another reason, if you'll look down there at the bottom, because that they can call that code stroke, that the people that come in by ambulance to the emergency department get to the MRI machine twice as fast as a person that walks in off the street. There again, that saves you time because you've called an ambulance. They're able to call, get things started before you ever even get there. And then a third reason to call an ambulance, a good reason to call an ambulance, not all hospitals are created equal. Some hospitals are better at taking care of stroke. I'm going to show you some later that's better in taking care of a stroke. But some hospitals are stroke ready. They can do more for a person having a stroke than other hospitals. The ambulance personnel know that. They know which hospital is best. So that's the third reason to call an ambulance, is so that you can make sure you go to the right hospital if you're, somewhere where it's the same distance between hospitals or something. So does everybody understand? I want you to be aware that that's going to be your best, your fastest option instead of trying to drive there or drive somebody there is to call that ambulance. So there's a condition now. Have you ever heard the word mini stroke? I think everybody has, right? The National Stroke Association hates the word mini stroke. The word mini stroke seems like it makes it sound like that stroke is not very serious. That's not a very serious condition, and it is a serious condition. What a mini stroke is, the medical term is a transient ischemic attack, or we call it TIA. And what they are is the blood gets cut off to the brain just temporarily, or just long enough where it shows signs of stroke. So if you're looking at somebody and they're having signs of stroke, you don't know if they're having a hemorrhagic stroke, you don't know if they're having an ischemic stroke, or you don't know if they're having a TIA, because the signs and symptoms are the same for all of them. So what happens with a TIA is that a person starts having these signs and symptoms. They may decide, I need to go to the hospital, and then all of a sudden, they go back to normal. The condition, those conditions leave them. They're talking normal now. They're acting normal now. It's like, I'm okay. I don't need to do anything. That is a major disaster waiting to happen. A TIA is a warning sign that you are going to have a future stroke. As a matter of fact, up to 40% will have a stroke, a lot of them within the next 48 hours after experiencing a TIA. So if you experience a TIA, you still need to follow up as quickly as possible and be seen by a healthcare provider, okay? But the symptoms are the same. The symptoms usually resolve in a few minutes or a few hours. It's important to seek that medical attention. Now, if you're like my grandparents were, the hospital is where you went to die. They just did not want to go to the hospital. And they would sit around, if they were having signs of stroke, they'd sit around nearly all day long. And when the symptoms, if they went away, it's like, I'm fine. If they didn't go away after 8 hours, they're probably like, well, I guess I better go. Well, they done burn up their 4.5 hour period, right? But TIAs should be taken very seriously. So here's one of the big parts of the program, how to prevent strokes. Now, there's some strokes that can be prevented. There's some risk factors that can be prevented. And there's some risk factors you just can't do anything about. Some of those risk factors we can't do anything about is our age, okay? It's hereditary sometimes, so we can't do anything about heredity. So all of those, that's some things that we can't do anything about. But remember earlier from that slide, 80% of strokes are preventable if a person would reduce their risk factors. So let's look at those risk factors. Number one, blood pressure. Blood pressure is a big enemy for heart attacks and for strokes and for all types of cardiovascular diseases. Our body is only designed to work at a normal blood pressure. When our blood pressure stays high over long periods of time or years or whatever, then it wears, for lack of a better term, it wears out our blood vessels. It would be like putting a low pressure hose on an automobile where you need a high pressure hose. That hose is only designed to work at a specific pressure. So if you put it over there on that high pressure side, if it even works, it's probably not going to last very long because it wasn't designed to stay under that kind of pressure. And that's what blood pressure does. So how do we prevent? Well, you may not be able to do anything about your blood pressure, but you need to check it. You need to make sure you take your medications that if you have been seen by a doctor, work with that doctor to control your high blood pressure and keep that high blood pressure down. But high blood pressure is one of the big stroke risk factors for stroke. If you have atrial fibrillation, now a lot of people don't even know what atrial fibrillation is. Atrial fibrillation is an irregular heartbeat. And you can live with AFib, is what we call it for short. You can live with AFib and never know it. I know a lot of people that didn't discover they had AFib until they had another problem somewhere else and went to the doctor for that other problem, and they hooked them up to EKG and said, oh, well, did you know you have AFib? No, I didn't. But what AFib is, it's an irregular heartbeat, and it produces blood clots. And guess what happens with those blood clots? They start flowing through your body, okay? Now that blood clot makes it to one of those real small blood vessels in your brain, it can cause stroke. So if you have AFib, make sure that you work with your doctor to manage it, keep that medication, be aware of it, and keep it under control. If you smoke, stop. I think we all have these days know the disasters that goes with smoking. Smoking is hard on your blood vessels. It's hard on the vascular system. It's hard on high blood pressure. We just don't need to smoke. As a matter of fact, let me see what it says here. There's one resource that says smoking, if you are a smoker, you double the risk factor of having a stroke sometime in your life. If you drink alcohol, don't drink alcohol. Alcoholism, and here's the point: it says if you drink alcohol, do it in moderation. We don't want to start drinking, or good Baptists don't drink anyway, right? But basically, what it's talking about here is alcoholism. Alcoholism is hard on your cardiovascular system. It can increase your risk of having a stroke. Cholesterol, we know what cholesterol does to our blood vessels, our blood pressure, our health, our cardiovascular system. So we need to make sure we keep that cholesterol checked, and make sure we eat healthy and watch our fatty intake and that kind of thing. Diabetes, if you're a diabetic, you can't do anything about diabetes, but you can control your system, the way they work. You can control it by taking your medication and working with your doctor. If you keep your diabetes under control, then that will help reduce that risk factor. But if y'all know diabetes destroys our blood vessels. My dad had a toe taken off first, and then he had a leg taken off. But it's hard on our vascular system. So we need to make sure that you control your diabetes by working with your doctor. Exercise is good. It lowers your cholesterol level. Exercise is just good for the body. We know high salt intake is hard on high blood pressure. So you need to watch the amount of sodium you take, the amount of fat you take. And then any circulation problems that you may have at all, just work with your doctor to keep that managed and under control. These are things, that we all know and all have heard all of our lives. All right, so why don't people respond? What's causing us now to not be able to get there within that 4.5 hours? Well, here's some reasons. They don't recognize the symptoms. What was it that a while ago? 54% of people over 50 don't recognize symptoms. So now we need to recognize those symptoms with that BFAST acronym, that BFAST test. Denial, a lot of people deny that there's a problem going on, and if they think that there's something going on, they're afraid the doctor's going to tell them it's worse than what it is. So denial is a big reason why a lot of people just don't go to the doctor, don't call the hospital, don't call 911, don't keep their regular checkups. They may think nothing can be done. Oh, back in the day, my grandparents at Conway Regional Hospital, they can't do nothing, right? Last time I was there, they did this or they did that. They can't do nothing for me. Well, what other choice do you have? You need to go, because they're making advancements every day in medical science, so we don't know what they can do and what they can't do that day. Worry about costs, and that's a big one. Man, I can't afford an ambulance cost. I've heard that in all my life and all my career. And one of the things that I always told everybody that says, I can't afford an ambulance ride, I would ask them, what kind of price can you put on your life? What kind of price can you put on your health? An ambulance ride is a lot cheaper than if you wait and now you can't be fixed and now you got to stay in a hospital longer or you got to stay in a full-time healthcare facility. What's the cost of that? So, cost, we can't put a cost on our health and on our life. Some people think the symptoms will just go away. That's a biggie. People don't know. I got 4.5 hours. I'm gonna wait till this afternoon to see if these symptoms go away. If they don't, then I'll go to the hospital. Well, how many brain cells are dying every second that you wait from that morning to that evening? So the symptoms won't go away. And if they do go away, like with the TIAs, that's a warning sign. That's giving you a heads up. Danger, danger. You're fixing to have, you better get checked out. You're fixing to have a stroke probably in the next 48 hours. And then a lot of them fear or don't trust hospitals. And as I said earlier, my parents, hospitals was a place you always went to die. But here's the thing. You can tell them, I know you don't want to go in the hospital, but if you go early, you'll have to stay less time in the hospital. Then the longer you wait, the longer you're going to have to stay in the hospital. And then the longer you wait, you may even have to stay, in a full care facility now for the rest of your life. So these are reasons, and I think we all can relate to that. We've had parents, grandparents, and even ourselves, we've thought of this before, but those are some of the reasons why we don't respond to those symptoms. Now, we're getting down to some of the meat and potatoes here. This is the program that has designed all of this stuff, and it was started in Arkansas in 2008. The reason the program was started in 2008, Arkansas was #1 in the nation in stroke deaths. Unacceptable. So in 2008, somebody decided to do something about it. So they started a program called R-Saves. AR is Arkansas. The word SAVES stands for Stroke Assistance through Virtual Emergency Support. So basically what it is, there is a vascular neurologist on call in Arkansas 24/7. For hospitals that participate in the R-Saves program, they've got all these fancy equipment there, these telecommunication equipment. So if somebody comes there, they can start their treatment for them, and now they can call this vascular neurologist. On the screen, he's FaceTiming them, he's able to see them, talk to them, ask questions, and now he can provide that care like we talked about earlier. He can tell them, give them TPA, ship them to Little Rock, do this or do that. And that has dropped us now, we're like #5 now. So we're steadily going, the right direction. We didn't have nowhere else to go from #1. So now we're getting better, and a lot of it is contributed to this R-Saves program. Now, not all hospitals participate, but to give you an indication, I hope maybe y'all can read this stuff. Here are the hospitals, and there's 3 levels of hospitals when it comes to stroke. The red are going to be the most. That's your spoke sites. That's the sites that participate in the R-Saves program, that if you go there, then you're going to get on that telecommunications, and through virtual medicine, they're going to help treat you, and then you may get shipped to another hospital. This is a little bit older map. I can tell you now that the hospital in Conway County is a spoke hospital now. They participate in the program. As a matter of fact, the very first person they used the program on was actually a husband of a friend of ours. And, it was remarkable that it turned out the way it did. The blue one are spoke and receiving sites. Now notice there's not as many of those. I think there's only about 5 or 6. But Conway Regional Hospital is a spoke and receiving site. That means they can do telecommunications, but they also can do other things like thrombectomies and some stuff like that. So if a person ends up at Conway, they may not get shipped out as quickly as if they went to Conway County Hospital. They're going to ship you out a lot quicker than Conway Regional will. And then the last one are the receiving sites. These are the sites that has the most advanced treatment in Arkansas that will can best treat them. There's only 4 of them, and there's 2 of them there in Little Rock. There's one up in Washington County up in northwest Arkansas, southwest Arkansas down here. It's actually across, I think it's actually on Texas side, but I don't know if you can read that or whatever, but there's the spoken receiving sites. Now, I was talking to the medic that was here earlier, and from what I gather from him, Baptist Health here in Faulkner County may have moved up now. Now they may be spoke and receiving site as well, because he said they can do some thrombectomies there. But you can see with these hospitals, but again, there's some hospitals that don't participate. But now we have somewhere in the state of Arkansas, some of the statistics I was looking at earlier, the most rural places now are within 30 minutes to 60 minutes from a stroke-ready hospital. So that's making a big difference for saving those lives and moving down on that list. Okay, so we're drawn up to a conclusion here. So here's what I want you to take away from this class today. Know that BFAST exam. Put it on your refrigerator so you can look at it every time. Teach somebody about it. If they fail only one of those, or all of them, or multiple of them, but if you're going to call 911, it gets you there faster. It gets you to the MRI twice as fast. They know which hospital to go to. And if you go into cardiac arrest in the back of an ambulance, that's where you want to go into cardiac arrest at, okay? If possible, get that last known well time. So try to figure out the last time anybody has saw this person when they were acting normal. They will take that in consideration before giving that Braino. Just remember, you only got that 4.5 hours. And really and truly, 3 hours is what they're wanting. They're really wanting you within 3 hours. After 3 hours, up until 4.5, then it's to the discretion of that vascular neurologist. But it's really most effective when you get there within that 3 hours. So just remember that. Teach a family member about that BFAST acronym and why it's so important to get to the hospital. So you can help prevent strokes just by knowing the facts that you learned today. Do y'all have any questions before we close out?